right, we're going to start looking at the immune system tonight. We're going to break it down into leukocyte function. So we're going to go over the basic players that are involved within the immune response. Then we're going to go into the inflammatory response, which is innate immunity, and then we're going to go into adaptive immunity. I thought possibly kind of explaining the players would make it all make more sense when we get actually into the inflammatory response as well as the adaptive immunity. So you have to understand who they are, what the players are before we put them kind of on the playing field. Some of these things are going to be gone over multiple times because they are in multiple areas. I have tried to streamline it as much as possible, but there is some overlap. There are a lot of moving parts when we're talking about the immune system. By no means are you going to have a degree in immunology. We are just touching the surface of the immune system, explained so that you understand and you can become an adept clinician and be able to manage patients who have insults to their immune system. So when we're talking about the immune system, we have the innate immunity, which is inflammation, basically the inflammatory response, and then we have adaptive immunity. So to be able to understand all of the players, we have this nice little kind of slide here. We have our physical barrier, which is the epithelial, your GI, GU tracts, your mucous membranes. That is that first physical barrier. Then we have the second step, which is the innate immunity, which is that inflammatory response. So after the skin is broken, we have that insult into the internal environment, and whatever it may be, you stepped on a nail, you cut your finger with a knife, regardless of what the insult is, the exact same response happens, and that is called innate immunity. We have phagocytes, neutrophils, we have dendritic cells, natural killer cells, complement. They all are at the party. That is what happens immediately. After that, we start getting more into adaptive immunity. The adaptive immunity players are B lymphocytes, T lymphocytes, antigen presenting cells, and a host of other. These are the major players. So if we look who is involved, those major players, so we have professional killer cells for the innate party, and they trap the microorganism. Those are phagocytes that are neutrophils, monocytes, macrophages. Natural killer cells are also there in the beginning. We also have ways to kill the microorganism once we trap it, and that's that lysosomal pathway that we already talked about back in cellular biology. We have inflammatory plasma proteins, so these are circulating. These come from the liver. That's complement C reactive. We have antimicrobial peptides. They're called AMPs, such as defensins and cathelicidins. We have cell receptors, DAMPs, toll-like receptors, nods, PAMPs. All of those sound the alarm that we have a break in the skin and we have microorganisms and cell damage. We have other things such as cytokines, histamine, leukotrienes, chemokines, platelet activating factor, kinins, a host of other interleukins. All of those are involved in that inflammatory response. When we shift over to adaptive immunity, then we get into what is called cytotoxic cell killing, which is the T lymphocytes. And then we have humoral, which means in body fluids, and that is your B cells. Natural killer cells are from the same line as B and T lymphocytes, and they are present in the adaptive as well as the innate, so they kind of play both fields. We get these antigen presenting cells. These are the major things in the adaptive party because we have to be able to present the microorganism to the B and T cells so that we elicit an adaptive response. Those are dendritic cells and macrophages. We have major histocompatibility complex molecules. This is a way that we present antigen. This also involves our primary and secondary lymphoid tissues. This is what's going to provide long-term immunity against invaders. So one of the first things I want to do is go into leukocytes. So these are the major players. A lot of these cells that we just talked about are from the leukocyte line. So we're going to go into those. We also have a hematology lecture, and we'll talk about red blood cells and platelets at that time. We're not going to be talking about anything other than the white blood cells tonight because it goes with immunity. The leukocytes occur via a stepwise maturation process of CD34 plus stem cells. When we talk about maturation, so we have what is called a multipotential hematopoietic stem cell. So this is what's going to be present in the bone marrow. What happens then is the multipotential or multipotent stem cell will basically differentiate into two different lines. The first line is called the common myeloid progenitor. The second line is the lymphoid. As you can see, we have a line and we have two different lines of cells that come off of this. The myeloid progenitor is responsible for our platelets, so thrombocytes, red blood cells, the erythrocyte, mast cells, and myeloblast. If you see blast, it means it's a precursor cell and it hasn't differentiated yet. The myeloblast will then differentiate into basophils, neutrophils, eosinophils, and monocytes. Monocytes will then differentiate into macrophages or dendritic cells. This is what is called hematopoiesis. This is how we get our blood formation in the bone marrow. Over here on the lymphoid progenitor line, so we either get natural killer cells, it comes off the actual progenitor and goes right into natural killer, or we get these small lymphocytes. The lymphocytes will then differentiate into either T lymphocytes or B lymphocytes. And then B lymphocytes and T lymphocytes actually differentiate even further, but we're not going to go into that here. This is just for you to understand the lineage and where these cells come off. And any problems of the bone marrow can lead to accelerated destruction, increased or decreased production. So always think bone marrow where this is originating from. So non-neoplastic or neoplastic syndromes are where we get dysfunction in the leukocyte line. We have two types of lineage with the leukocytes. So we have the granulocytes, and then we have agranulocytes. Other ways to look at it are phagocytes and immunocytes. So the granulocytes are the neutrophils, basophils, and eosinophils, and that's basically because they have granular components within them. Agranulocytes are your lymphocytes, monocytes, and macrophages. They have a lot less or fewer granules in their cytoplasm than the granulocytes do. Let's take a look at the leukocytes. So we're going to take a look at granulocytes first, and you can see here how we have granulocytes and agranulocytes. The granulocytes encompass the neutrophil, eosinophil, and basophil. They have many membrane brown granules in their cytoplasm, and these granules contain enzymes capable of killing microorganisms and catabolizing debris ingested during phagocytosis. These granules also contain powerful biochemical mediators with the inflammatory and immune functions. These mediators, along with the digestive enzymes, are released from the granulocytes in response to specific stimuli. The biochemical mediators have vascular and intracellular effects. They break down debris from sites of infection or injury. They are capable of amoeboid-like movement called diapedesis, which helps move the blood cells through the blood vessels. First up are the neutrophils. So we also say that the neutrophils are called polymorphonuclear neutrophils, so PMNs. They are the most numerous and best understood of the granulocytes. They encompass about 55 to 67% of the total leukocyte count. The cytoplasm of the neutrophils contains small lysosomal granules and a central nucleus with 2 to 5 distinct lobes. And that's where we get this polymorphonuclear name from. Immature neutrophils are called bands or stabs. So if it takes 14 days from early precursors to maturation, and these early precursors are called bands or stabs. Either one is correct. They reach that fully mature state in the bone marrow, and these mature neutrophils are called the marrow neutrophil reserve when they're in there. Normally takes about 14 days for neutrophils to develop from the early precursors, like I said, and this can be accelerated by infection or treatment with colony stimulating factors. Chief phagocytes of early inflammation, then soon after bacterial invasion or tissue injury, neutrophils migrate out of the capillaries into the inflamed site where they ingest and destroy microorganisms. and debris, and they die within 1 to 2 days. So they are very quick-lived. They respond to several sources of chemotaxis, so being called to the party by macrophages releasing interleukin, basophil mast cells releasing histamine, and C-reactive induced complement activation. Next up are eosinophils. So these have large, coarse granules and constitute only about 1 to 4% of the normal leukocyte count in adults. They are also capable of amoeboid-like movement. They are from the bone marrow, from the myeloblasts. These are all from the same line. The granulocytes, neutrophils, eosinophils, and basophils are all from that same line. So they use pattern recognition receptors, and they ingest antibody antigen complexes and viruses. So antibody antigen complexes and viruses. They respond to mast cell basophil chemotactic factors. They have these highly aggressive secondary granules, and they have basically are toxic chemicals, and they are very destructive towards parasite and viruses. And here's just a couple of them. Major basic protein, eosinophil cationic protein, EOS peroxidase. So there's one of those peroxidases again. And then we actually have an EOS-derived neurotoxin as well. They contain pro-inflammatories such as leukotrienes, prostaglandins, platelet activating factor, and then they also contain anti-inflammatory enzymes such as histaminase. Next up are basophils. They comprise less than 1% of the total leukocyte population in an adult. They also have cytoplasmic granules that have an abundant mixture of biochemic mediators, such as histamine, bradykinin, and then they also have chemotactic factors that attract neutrophils and eosinophils. Stimulation of basophils actually induces vasoactive lipid molecules, and that is these new. So this process here to get these new mediators is this here. Stimulation of the basophils leads to synthesis of vasoactive leukotrienes and cytokines. The cytokines include interleukin 6, interleukin 10. This is by way of T helper 1 and T helper 2 cells that favor B cell differentiation. So like I said earlier, this stuff is all linked together. And then that guides B cells into secreting IgE. Basophils are often increased at the sites of allergic reactions. There's also a response to things like ectoparasites such as ticks, and they're high yield for also hypersensitivity. IgE hypersensitivity reactions. Mast cells are similar to basophils. They are generated from a different precursor cell, though. If we go back to our flow chart here, you can see here that mast cells come right off of the common myeloid progenitor. They do not stem from the myeloblast, which is what we get the rest of our major white blood cells from. Originate in the bone marrow, from which they migrate in an immature form into tissues. They reside in the vascular connective tissues just beneath the epithelial cells. So basically we have our skin epithelial cells, and then the mast cells kind of ride underneath here and highly in the connective tissue. Also in the submucosal tissues such as the GI tract, respiratory tract, and then that dermal layer just below the skin. They play a central role in inflammation, so they are highly involved in the innate response. I have a nice little schematic here for you. I thought this was a really good synopsis of the mast cells and what they do. We have two types of mast cell kind of release. We have degranulation, which is the immediate response, and that just basically means that they are going to release a whole bunch of factors. We have a synthesis response, which is more long-term. So you can see here leukotrienes, prostaglandins, cytokines, growth factors, but it's more long-term. What these all are up here are what basically stimulate the mast cell. So we have bacteria, viruses, we have injury, interleukin 1, antibody IgE mediated mechanism, so that's that cross-linking, and then we have complement. So there's C3a and C5a, which we will talk about more when we get into the actual immune response. So here you can see we have heparin, we have certain cytokines that are released, interleukin 4, tumor necrosis factor, histamine, high yield mast cells release histamine. We also have a chemotactic factor and eosinophilic chemotactic factor too. So they're going to bring in both neutrophils and eosinophils. So very important in the innate inflammatory response, which we'll get into in a little bit. Central role in inflammation is big role, number one role. Also involved in healing with fibroblasts. All of the activation leads to increased permeability of those blood vessels, smooth muscle contraction, and chemotactic factors too. So here are the chemical mediators that are released: histamine, interleukins, proteoglycans, heparin. There is that degranulation or synthesis, and those are all the things that will activate it. So tissue trauma, complement proteins, cross-linking, activated by other mediators such as leukotrienes, prostaglandins, and platelet activating factor. Again, this is a nice synopsis of what the effects of degranulation and synthesis of the mast cells is. Agranulocytes. So the agranulocytes are the monocytes, macrophages, and lymphocytes. So now we're down here and here. So they have less granulocytes in the cytoplasm. So you can see the difference between the granulocytes and the agranulocytes. We have monocytes and macrophages are larger and fewer digestive vacuoles than the granulocytes. Lymphocytes do not have any enzymes to digest. So first up are the monocytes. This is part of the mononuclear phagocyte system, also known as the reticuloendothelial system or macrophage system. So either one of these is interchangeable. They mean the same thing. What this means is it consists of specialized endothelial cells in the bone marrow, spleen, and lymph nodes, promonocytes and their precursors in the bone marrow, monocytes in the blood, and then the portion of the macrophages that reside in the tissues are also called something else. So basically you have bone marrow makes the monocytes, and then it's either going to go macrophages or dendritic cells. If the macrophages get into the tissues, they're called something else. And we'll hear about these more when we get into our systems. So if it's in the lung, we call it alveolar macrophages. If it's in the liver, we call them Kupffer cells. If it's in the spleen, they're in the red pulp. If it's in lymph nodes, we call them medullary macrophages. So they all have different names based on their locations. So after they get into the tissues, they're called macrophages or dendritic cells. So blood and tissue. So they migrate to the variety of tissues, mature into tissue macrophages or dendritic cells. Other monocytes are circulating macrophages. The dendritic cells look different than the macrophages. The dendritic cells have those arms. Once they leave the circulation, they do not return. The exact turnover is unknown. They can live months to years as far as we're aware of it. Monocytes have a horseshoe nucleus. So let's take a look at macrophages. So macrophages, their normal role is to remove old and damaged cells and large molecular substances from the blood. So they're basically the cleaners. They have cellular targets of phagocytosis. Remember, we talked about phagocytosis before. Macrophages are huge in phagocytosis. And they also have a large role in circulating senescent or damaged erythrocytes and platelets, and then that's primarily removed via the spleen. Dead neutrophils in the circulation and the site of inflammation, and then cells undergoing apoptosis. So they're heavily involved in cleaning up the mess. We have erythrocytes, and they then go into the spleen. We have neutrophils at the site of inflammation, old senescent cells, and also eliminating microbes. So huge in keeping that cellular housekeeping, overturning, and making sure that everything stays cleaned up. Non-cellular targets include antigen antibody complexes. So that is going to be antigen antibody complexes, and that's going to be huge for our adaptive immunity. They are huge in APC, which is antigen presenting cells. So these guys are big with adaptive immunity, and we'll get more into that when we get over there. The dendritic cells are the other major antigen presenting cell. basically what happens is we ingest that microorganism, and then they break it down, and then they basically take a little bit of the antigen and express it on top of the cell surface. And the CD4 T cells, CD8 T cells will then recognize it, and that's how we get our adaptive immune response. And that's how it's specific to antigen. And again, this is just kind of an introduction to these cells. We're going to be going much more into it when we get into immunity. They are also present in innate and adaptive, and they are kind of that bridge. So they represent a key feature of that. Remember that the dendritic cells have those arm-like projections. All right, and that's how you can tell them apart from the macrophages. Lymphocytes. So these represent 36 of the total leukocyte count. They are present in the circulation and lymphoid organs. They are the primary response for the immune response when we're talking about adaptive immunity. Hardly any of these are present in acute inflammation. They are all related to adaptive. They circulate and reside then in secondary lymphoid tissues as mature T cells, B cell, plasma cells, and we'll talk about that more when we get into adaptive immunity. They do not contain any enzyme-filled digestive, so no enzymes or digestive vacuoles. All right, so there's none of that in lymphocytes. The span of the life of a lymphocyte is days and months, years. This is what gives us our long-term immunity. They develop from precursors in primary lymphoid tissues, either the bone marrow or the thymus. We get B and T cells and its progeny. We get clones, and they express a single antigen receptor. The total population of lymphocytes is huge, tens to hundreds of millions of antigens they will recognize, but each lymphocyte recognizes one antigen. It's absolutely crazy when you think at the breadth of coverage that these lymphocytes give us. The immune system is just amazing and requires respect. Just awe-inspiring how the body protects us from invaders. So the B lymphocytes, they are from the bone marrow, and that's actually where we get the B from. So bone cells produced in the bone marrow, B lymphocytes, they undergo immunoglobulin arrangement, and this is all DNA determined. They are naive B cells that express IgM and IgD. B cell activation occurs, and then they become either a plasma cell or a memory cell. So memory B cells, this is where we present that antigen, okay? So we have an antigen presenting cell, we present the antigen, and then we get memory to that antigen. So whatever microbe, that's where we get memory B cells. The plasma cells are basically our antibody factories. So we get that presentation, we now have the idea of what the bacterium is, and we ultimately will get memory to it, and then we will also produce antibodies. So that's what these are. So we have memory cells and we have little antibody factory cells. So once this happens, this is where we get that flood of antibodies in the immune response, is from the B cells. Very important with being able to fight off invaders. The other lymphoid tissue is T cells, and this is involved in the cell-mediated or cellular immunity. So bone marrow as progenitor T cells, and then they migrate to and develop in the thymus. T cells, thymus. They undergo rearrangement, and they get a T cell receptor. This is also unique. Then the progenitor cells will evolve into either CD4 T helper cells or CD8 cytotoxic T cells. So these are cell-killing cells, and they're involved with killing those invaders. And then the CD4 cells are what basically help us with the immune response. So you can see here CD4 cells, and they help B sites become activated and create memory B cells and plasma cells. So T cells and B cells work together to give us our immunity. The T cell receptor is the surveillance for antigens and recognizes the histocompatibility molecule. We'll talk more about that later. So it recognizes antigens on the surface of the macrophages. That is that antigen presenting cell. The elimination of virally infected cells, tumors, or foreign bodies, release of cytotoxins to kill. And then they are also involved in delayed hypersensitivity reactions. Natural killer cells. These cells resemble large granular lymphocytes, so they do have granules in there. And when we take a look at our hematopoietic cell line, we have the large killer cells are over here, and you see that they have the granules within them. Small lymphocyte, T lymphocyte, B lymphocyte, no granules. So that's how you differentiate these guys. So natural killer cells are really unique and cool. They have involvement in killing cancer cells as well as virus infected cells without previous exposure. So this is how they differentiate between T cytotoxic cells. C cytotoxic cells must be activated by an antigen. So they have to be exposed previously. Natural killer cells do not need a previous exposure, meaning that they will kill without being exposed. They also have the capacity to activate T cells. So when we talk about adaptive immunity, this is another way that we're going to be able to activate T cells is natural killer cells. Phagocytes and also then some other cytokines are produce a couple of cytokines that regulate the immune response. These guys develop, so they're found in the marrow and then peripheral blood and spleen mainly. We're going to talk about antigen presenting cells. So these are highly specialized hunter cells that capture the antigen and present it and display it to lymphocytes of the adaptive immune system. So the main antigen presenting cells are dendritic cells, B lymphocytes, and macrophages. And this is basically what happens. So here's a dendritic cell. We have antigen presenting CD8 cytotoxic T cells will ultimately kill it. And then we also get memory from that. And we'll go a lot more in depth, just kind of giving you the overall picture of everything that's involved in the immune response, all of these cells. Here is a nice little synopsis of the white blood cells. You can see what they look like, what the percentage is, what their nucleus looks like, and then the function. Then also their lifetime and what are the main targets. So this slide is high yield. I'm not going to go over this. We just kind of went through this all together, but this is a nice little slide that you could print out and study from. Next up, the lymphatic system is heavily involved in immunity, obviously. So we're just going to take a few minutes here to go over the main components of the lymphatic system. So closely integrated and all are linked to the hematological and immune systems. So lymphoid organs are merely aggregations of tissue. Primary are the thymus and the bone marrow. So those are primary. Secondary is your spleen, lymph nodes, tonsils, Peyer's patches, which are in the small intestine. So they are sites of proliferation, residence, differentiation, and function of lymphocytes. So high yield, that is big for the lymphocytes, as well as the mononuclear phagocytes. So those are those monocytes and macrophages that we talked about. So there is, a basic picture of what the lymph system looks like. We have lymphoid tissue spread out all over the body. So let's take a look at the spleen. So it is a major lymphopoietic organ, 25% of the total lymphoid mass of the body. We have the reticular endothelial system, can react and enlarge quickly after the onset of infection and inflammation. Its function is to remove particulates such as opsonized bacteria, antibody-coated cells from the bloodstream, so a major cleaning mechanism. It filters blood-borne antigens, cleanses the blood through action of the mononuclear phagocytes, initiates immune responses to blood-borne macroorganisms, particular bacteria, destroys aged red blood cells, also serves as a reservoir for blood. So very important to the hematologic and immune system. So the spleen is concave. It's an encapsulated organ. It is about the size of your fist, and it's located in the upper abdominal compartment. The compartments contain, we have connective tissue, strands of connective tissue called trabeculae, and then we have, what's divided into splenic pulp. We have white and red. The white pulp is embedded within the red pulp. The spleen is interlaced with many blood vessels and also has their ability to store the blood. Blood that circulates through the spleen comes from the splenic artery, which branches from the descending aorta and re-enters circulation through the splenic vein and into the portal vein. So this goes into the portal vein. So arterial blood enters the spleen, first encounters the white pulp. This is the white pulp in here. So you can see the arterial blood supply comes in, white splenic pulp, and that consists of masses of lymphoid tissue containing macrophages. So this is the white pulp is lymph tissue, and then we have macrophages and lymphocytes. And then we get T cells. We also have lymph follicles, and they have the B cells. So the lymph follicles get the B cells. And this is more peripheral. This is the chief site of immune function within the spleen. So we'll have blood-borne antigens encounter the lymphocytes, initiating the immune response. And then we get conversion of lymphoid follicles into germinal centers, where the B cells will then proliferate and differentiate during humoral response. So we get differentiation. So the red pulp of the spleen, so that's up here. So some of the blood that enters the terminal capillaries continues through the microcirculation and enters the highly distensible storage venous sinus in the red pulp. So this is more of a storage. So the red pulp is more of a storage area. This is capable of storing up to 300 milliliters of blood. Sudden reductions in blood pressure cause the sympathetic nervous system to stimulate constriction of this. It results in an expulsion of the blood into the circulation, and we get up to 200 milliliters of blood into the venous circulation, which actually brings it up about 4%. So high yield when we have a drop in blood pressure. The red pulp contains those interconnected resident macrophages, principal site of splenic filtration. So there's another way that the immune system, we have macrophages within the spleen, and they easily phagocytize old, damaged, dead blood cells of any kinds. Chiefly, this is where we get the erythrocyte cleaning, as well as microorganism, macromolecules, and then particulates of debris. The spleen is not necessary for life. However, splenic absence for any cause, secondary effects on the body, for example, we'll get leukocytosis, often occurs after splenectomy, suggesting that the spleen has some control over the rate of proliferation of the leukocytes in the bone marrow and their release into the blood system. And then circulating levels of iron may also decrease. So there must be some role of the spleen in the role of iron as well. The immune response to encapsulated bacteria is also then severely diminished, so huge. And that is items such as Haemophilus influenzae, Streptococcus pneumoniae, Neisseria meningitis. All of those would put the patient at higher risk for disseminated infections and sepsis. So here is just alterations in splenic function. So there can be multiple ways that we get problems within the spleen, such as cirrhosis, heart failure, and that's related to, remember that we go into the portal vein. So if we have any problems there, we can have a congestive issue, which backs up into the spleen. We can have some malignancies in there, such as acute chronic leukemias, polycythemia vera, multiple myeloma can affect splenic function. Inflammation, such as sarcoid or lupus, hematologic states, this is basically hypersplenic, such as a hemolytic anemia or sickle cell in children. Non-malignant infiltrated diseases, amyloid and lysosomal disease, and then infections such as mono and CMV. The lymphatic drainage and nodes. So these are collections of interstitial fluids from the tissues and transported to the lymph through the vessels. They will increase size when they're in response to an infection, obviously. So the lymph nodes are distributed throughout the body and provide filtration of lymph during its journey through the lymphatics. Each lymph node is encased in a fibrous capsule, branches of which are called trabeculae, extend upward in partition to the node into several compartments. We have reticular fibers of connective tissue, also dividing the compartments into a meshwork. We have the outer cortex. So outside is always the cortex, and we have the inner, which is the paracortex, and then we have an inner medulla area. Lymph enters through multiple small afferent lymphatic vessels into the subcapsular sinus, just beneath the capsule, drains into the cortical sinuses and then into the medullary sinuses. The lymph is collected, leaves the node by way of afferent lymphatic. Afferent in, efferent out. Primary site for the first encounter between antigen and lymphocytes. Lymphocytes enter the lymph node from the blood through the postcapillary venules by means of diapedesis across the endothelial lining. B lymphocytes tend to migrate preferentially to the nodes in the cortex and medullary, where T lymphocytes migrate to the paracortex. Macrophages reside in the lymph node and help filter that lymph of debris, foreign substances, and microorganisms. Also, we have dendritic cells, which remember that the macrophages and dendritic cells are big for antigen processing functions. Thymus is next. So this is a bilobed lymphoid organ located in the superior mediastinum of the thorax. So that's the thymus right there. After puberty, it decreases in size, and it's small and fatty in adults after degeneration. This is the primary processing site and maturation of T lymphocytes. Remember, thymus, T lymphocytes. That's what they're named for. While they're in the thymus, the T lymphocytes do not respond to pathogens or foreign organisms. This is just a place that they get matured. The thymus also produces thymosin, is a hormone that helps stimulate the maturation of the T lymphocytes in other lymphatic organs. So the thymus gland will not function throughout a full lifetime, but it has a big responsibility when it's active, helping protect yourself against autoimmunity, and also plays a vital role in lymphatic system. Thymopoiesis is the process where T cells mature into cells that will fight off the foreign invaders. So they mature and then they go into the lymph nodes. So when we're talking about the lymph system, we get lymphadenopathy. So this is basically enlarged lymph nodes. What you look at is size, consistency, fixation, painful versus painless. Inflammation of the lymph node is hyperplasia of the regions within the node, and it's directly related to many potential causes. Biopsy is sometimes the best way to reach a definitive diagnosis, but it should be used very cautiously or judiciously. Your history focused physical exam leads to that differential, what is involved in addition to getting some lab work. Disorders involving leukocytes range from deficiencies in the quality and quantity of the leukocytes, which we call leukopenia, to increased numbers of leukocytes, which is leukocytosis. So we're going to take a look at these. Many hematologic disorders are malignancies, and many non-hematologic look at bone marrow issues, which affect the leukocyte production. When we talk about leukocyte and lymphoid issues, a lot of it is related to malignancies. So we will talk about malignancies a little bit more in the cancer section. Here tonight, I'm just going to talk about really the alterations in leukocyte function, which would be those quantitative leukocytosis, leukopenia. So leukocytosis is a count higher than normal, and it can be caused by a variety of things. It occurs via normal protective responses to physiologic stressors, strenuous exercise. Certain medications may induce leukocytosis. Emotional changes, temperature changes can cause it. Pregnancy, surgery, anesthesia, hormones such as cortisol. So pretty much when we're talking about leukocytosis, any type of stressor can cause, either a physiologic or a pathologic. Pathologic is related to malignancy or hematologic issues. The other thing, tissue necrosis, remember that we get an inflammatory response after we have necrosis. We have something called a marginated pool, and we're going to take a look at this in a few minutes. And that is marrow neutrophils, including the bands, are kind of stored in this marginated pool. What happens is we have increased demand versus supply, and then we get a left shift. So we're going to talk about that in a few minutes here. High cortisol state, such as either a pathologic condition or the use of steroids, impairs leukocyte adhesion, leading to a reduce of the marginated pool. When we're looking at leukocytosis, you must always, if you suspect a infection, you need to get a differential. We usually assume that leukocytosis is increased circulating neutrophils. Your differential is going to confirm, as well as tell us if there are any other associated rises in your monocytes, eosinophils, basophils, or lymphocytes. So when we're looking at monocytosis, infection, hematologic, physiologic, bacterial endocarditis, tuberculosis, myeloproliferative disorders. If we're looking at eosinophilia, so allergy, infection, malignancy, basophilia, so this would be infections such as measles or chickenpox, myeloproliferative disorders like polycythemia vera or chronic myeloid leukemia. And then we get down lymphocytic leukocytosis, which would be increased circulating lymphocytes. We see that with viral infections such as infectious mononucleosis, CMV. So the leukomoid reaction is considered the shift to the left. All right, I'm sure you've heard providers talking about this shift to the left. So what is this? So this shift to the left is basically premature release of immature white blood cells in response to depletion of the mature white blood cells. Basically, your demand infection exceeds the supply. So we have cells being released from the line. So we have that promyeloblast, we have a promyelocyte, myelocyte, metamyelocyte, and then a band neutrophil. Ultimately, we want to get segmented neutrophils because that means that it is mature. So what happens is we get release of these band neutrophils, and that means that they are immature. Many diagrams present cellular differentiating and maturation from left to right instead of vertically where it's supposed to be. What we see with the left shift is that we actually go backwards from left to right. So we're doing a left shift. Have the circulating pool. So this would be in the blood vessel. So those are going to be in the blood for several hours at a time. And then they would go into the organs and tissues. What's interesting about this marginated pool is we talked about the steroid response. So these guys basically hang out on the endothelium and kind of have adhesion molecules, and they're kind of just, hanging out there. What happens with steroid hormones is they break these bonds of the adhesion molecules, and it results in them being put into the blood vessel, and that's where we get increased leukocytes and leukocytosis from steroids. So ultimately, that's what it means by a left shift, is that we're going to the left side of the diagram, cell differentiation. When you take a look at a white blood cell differential, so you will get the normal values. If there are bands present, it will say that there are bands or stabs present. So here's a shift to the left is what it looks like. So you will see the bands being elevated. So next is leukopenia or neutropenia. So this is the decreased circulating neutrophils. When we're talking about levels, it's less than 1,500 cells per microliter in most clinical laboratories. Usually, we're talking about neutrophils, and that's because they're the most abundant white blood cells in the peripheral. We also can do an absolute neutrophil count, which is the number of neutrophils plus bands, and then we would basically times the white blood cells times the percent divided by 100, and we get the absolute neutrophil count. Obviously, this is big with your cancer patients. We do have degrees of leukopenia, mild, moderate, and severe. So when we're looking at that etiology of leukopenia, you're looking at is it inherited or congenital? And here are the most common kind of congenital disorders, such as benign ethnic neutropenia, familial neutropenia, or congenital neutropenia. Then we have acquired disorders, such as infection medications, nutritional, autoimmune, rheumatologic, and then we also have hematologic malignancies. Lymphocytosis is an abnormal increase in the lymphocyte count. It may be a transient infection or one of a number of benign or malignant conditions. Consider malignant proliferation versus reactive. Reactive includes viral causes such as CMV, mumps, rubella, influenza, bacterial pertussis, cat scratch fever, toxoplasmosis. Others would include a drug hypersensitivity reaction, stress, or a thymoma. This is rare in acute bacteria. It is more common in viral, especially EBV, Epstein-Barr virus, which is the causative agent in mono. Lymphocytopenia is an abnormal decrease in the lymphocyte count. This also may be aplasia, immune deficiency, or we can get destruction related to some drugs, viruses, or radiation. It can also occur in individuals for no apparent reason. Other conditions associated with lymphocytopenia include lupus, TB, aplastic anemia, high cortisol state, and then cytotoxic chemotherapy or radiation. Another big one would be HIV, because we are destroying our immune system with HIV. Lymphedema, so this would be, now we're going to kind of shift over into some alterations in the lymph system. So lymphedema is one of the big ones. It's a chronic progressive swelling of tissue with the protein-rich fluid. It is usually developmental, which we classify as primary lymphedema, or acquired, which is secondary. Disruption to that lymphatic system. The extremities are most affected, followed by genitalia. If it is a nematode infection, filariasis, which is endemic to Africa or Asia, malignancy is the main cause of secondary lymphedema and cancer-related treatments. And of this, breast is the most common cause of lymphedema for breast cancer. So your etiology and epidemiology, again, cancer treatments, especially breast, lymph node dissection, which is common with breast cancer. You can get lymph node dissection with some other cancers. Lymphatic hypoplasia, so is there something wrong that you have hypoplastic tissue? Parasitic nematodes, injury to the lymph. It does account for 140 to 250 million worldwide. Primary lymphedema is usually congenital and developmental, but it is still quite rare. So what's interesting is it's a male to female ratio is equal, but we have more preponderance of male presentations in infancy and more females in adolescence when we're talking about the children. And secondary lymphedema is usually secondary to malignancy. The pathophysiology of the lymphedema is basically the lymphatic system is supposed to return that interstitial fluid and proteins back into the circulatory system. There's particulate matter, microorganisms are filtered, immunologic response, we just talked about the lymph system. There's dysfunction of the channels or nodes leads to lymph accumulation into the superficial interstitial space. So we're basically altering your oncotic pressure and it filters out. We have lymphatic stasis and we have fat hypertrophy with associated thickening of the subcutaneous tissue, as well as continued immunologic dysfunction related to a non-functioning lymph tissue. We have extra interstitial proteins that cause inflammation and fibrosis, leading to a cycle of further damage. It will clinically present as painless unilateral swelling of the extremity or genitalia. You will have a positive stemmer sign. A positive stemmer sign is the inability to pinch skin on the dorsum of the second toe. So basically you can't pinch with your thumb and index finger. If you have a negative stemmer sign, it does not exclude lymphedema. You also have limb heaviness or weakness, non-pitting edema, classic, and then you will have those skin changes remain related to those inflammatory changes that happen. You will test it with is a lymphoscintigram, and this is one of the most accurate tests for lymphedema, and it's a radiographic image taken with TC99 labeled antimony, sulfur, or albumin injected into the web space, and then they obtain images, and then it will basically state that there is dermal black flow, delayed or absent transport, and then lack of visualization of the lymph nodes. You also can get MRIs or CTs of the affected limb, ultrasounds. You can do a blood smear. You would be looking for those nematodes, and then genetic testing. So genetic testing should be ordered in anybody with primary lymphedema. All right, that's it. Looking at a few alterations within the WBC and immune system.